Next speaker will be Dr. Peter Campuchiaro, who will present improved cone function in retinitis pigmentosa by oral N-acetylcysteine.
Thank you. I'd like to thank Judy and Mark for inviting me to participate. These are my disclosures, none of which are relevant to this talk. Rod photoreceptors die from a mutation in retinitis pigmentosa, eliminating 95% of the cells in the outer retina. There's decreased oxygen utilization and increased tissue oxygen in the outer retina, leading to production of reactive oxygen species, which damage critical macromolecules in cones, resulting in decreased cone function and death. N-acetylcysteine is a derivative of L-cysteine, which by itself remedies reactive oxygen species, detoxifies them. In addition, it is a substrate for glutathione, which is a major component of the antioxidant defense system. NAC is approved for acetaminophen overdose, and it's extremely effective. In patients who have acetaminophen overdose, the acetaminophen is metabolized to aldehydes in the liver, causing severe oxidative damage and liver toxicity with hepatic necrosis. NAC given in a timely way is life-saving. In RD10 mice, model of retinitis pigmentosa, oral NAC dose-dependently improves cone survival and cone ERG function. The FIGHT-RP study was a dose escalation clinical trial testing NAC in 30 patients with retinitis pigmentosa. There were 3 cohorts of 10 patients given 600 milligrams BID, 1,200 milligrams BID, or 1,800 milligrams BID for 12 weeks, and then dose escalated to TID. The primary outcome was safety, and the major secondary outcome measures were mean change in baseline best-corrected visual acuity, mean change from baseline central retinal sensitivity by microperimetry, change from baseline EZ width, and NAC levels in aqueous and plasma. There were 11 drug-related adverse events, 9 of which were related to the gastrointestinal tract. 8 were mild, transient, and resolved spontaneously. 3 were moderate and occurred during TID dosing and resolved with dose de-escalation to BID dosing. The maximum tolerated dose was 1,800 milligrams BID. With oral dosing of NAC, there were quite substantial levels intraocularly. In cohort 1, the mean aqueous level was in the range of 100 nanograms per mil. In cohorts 2 and 3, it was in the range of 300 nanograms per mil. There was no increase or significant increase in aqueous levels with the dose escalation from BID to TID dosing. And in each patient, there was a good correlation between aqueous levels and 1 hour post-dose plasma levels. The mean baseline best-corrected visual acuity was 72 letters in cohort 1, a Snellen equivalent of 20/40. It was 74 letters in cohort 2 and 75 letters in cohort 3, which is the equivalent of 20/32. Despite these very good baseline visual acuities, there was a gradual progressive improvement in best-corrected visual acuity in each of the 3 cohorts, which was statistically significant by linear mixed model. You can see that normally with spontaneous changes that are random, there's not the same consistent steady increase. Macular sensitivity was measured by the Macular Integrity Assessment microperimetry instrument. It measures the retinal sensitivity at 68 loci throughout the posterior pole, and averages them to produce the mean macular sensitivity. Like visual acuity, mean macular sensitivity progressively increased in each of the 4 cohorts, and it was statistically significant in cohort 3. The difference between baseline and week 24 mean macular sensitivity was statistically significant. This shows the best heat map of a patient in cohort 1. And notice that this area improves 12 weeks after initiation of treatment, is maintained 24 weeks after, and much of this is sustained 12 weeks after stopping treatment. This shows the fundus image of this patient, which shows the macular sensitivity at all 68 loci. The retest variability for this is 6 dB, or is 4 dB, and so a difference of 6 dB tends not to be due to random variation. These circles show the number of loci that had at least a 6 dB improvement during treatment. A change to green indicates that it's reached the 6 dB threshold, and change back to yellow shows regression. This patient had a number of loci that were increased by at least 6 dB, many of them reached threshold by 12 weeks, and many maintained that benefit 12 weeks after stopping treatment. This was not consistent with many of the other patients who showed regression. This patient, this is the best mean macular sensitivity at baseline for this patient. You see this arcuate scotoma, which improves on treatment, and the benefit is maintained. You see the number of loci that improved by 6 dB or more, but only one reached that threshold by 12 weeks, where all of them did by 24 weeks, and then some regressed. This is a patient from cohort 3, and you see this arcuate scotoma, which improved at 12 weeks, further improved at 24 weeks, and then regressed after treatment was stopped. Again, the improvement was gradual, with only one of these loci reaching threshold by 12 weeks, and you see that there was regression after treatment. This is a patient from cohort 3 who showed very good retinal sensitivity at baseline, but note the gradual improvement in this inner area of particularly good retinal sensitivity during treatment. So in summary, preclinical models show that oxidative damage contributes to cone cell death and dysfunction in retinitis pigmentosa, and NAC promotes cone function and survival. The FIGHT-RP clinical trial demonstrated that oral NAC is safe and well tolerated with a maximum tolerated dose of 1,800 milligrams BID. And this dose resulted in good intraocular levels. The gradual improvement suggests that cone function may improve with NAC over time. So a large multi-center placebo-controlled clinical trial is needed to determine if long-term oral NAC can promote cone survival and function. And I'd like to acknowledge the people in my lab and clinical trial group who participated in this. Thank you very much.